The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to another edition of Your Health, Your Choice. In the midst of this pandemic, we want to present you with a few updates, as usual, with Dr. Claude Khan.
Okay.
And we will also be tackling a non-communicable but equally chronic disease, heart failure. So first of all, I guess you have a few recent developments that you'd like to share with us about COVID.
On the last program, I mean, just to say that we're not live.
Yes, we are recording our program today.
Yeah. So, we're not live, and because of the COVID-19 situations. So anybody who wants to send in questions, they can ring us on WhatsApp is a better means of contacting us on 482-4269. So, Linda, we're still in the midst of COVID-19, and it's the lockdown situation in Trinidad may change over the next week or two, but I just wanted to highlight two or three latest developments, and people who have been following the news might be aware of this. So there's a drug, remdesivir. It's an antiviral drug, and it's just been approved. It's been given what is called an emergency authorization by the FDA. That's the Food and Drugs Association.
So is this a new drug, or is it something that has been used for other cases?
So that's a good question. Actually, remdesivir was developed a few years ago for hepatitis C and Ebola. Now, I'm not sure if it was ever used and how successful it was, but it's now been trialed. It is showing some efficacy in first in vitro, that means in the lab, in terms of replication of the virus. What we have to bear in mind, though, with remdesivir, because, there was the whole thing about chloroquine,
yes.
Where prominent person in another country made some statements about chloroquine, and people started buying it, and there was a shortage because it's used as an anti-malarial drug and also for lupus. And now it's been shown not to be effective against COVID-19, and this is where, Linda, I'm passionate about science as opposed to anecdotal evidence. So someone can stand in front of a podium and say, yeah, great, chloroquine can be used and let's stockpile it. And even a former Minister of Health in Trinidad was advocating the stockpiling of chloroquine. Now, just 4 weeks later, we've shown that it's not effective. So remdesivir has shown some efficacy, but two things. It's an intravenous drug, so it has to be given in a hospital setting, and it's being used for fairly ill COVID-19 patients. So it's not a drug that we are saying that's going to be used to prevent infection, but it's a drug at this stage that can be used in an emergency situation in a hospital setting for severely ill COVID-19 patients.
Well, that's the thing about this whole pandemic. We know so little about it, and information is evolving as the disease spreads. And we're talking about severe cases where you would use this drug, but we know that there's several cases where people have actually experienced symptoms and they've been tested positive, but they've been able to carry on as normal. So they're basically carriers.
So that's one of the things that we wanted to point out, that the incubation period for COVID-19 is from 1 to 14 days. The incubation period. So you can be asymptomatic and be a carrier, and that was the big problem in the early stages of COVID-19, both in China, where we still think that's where it started. I know there's ongoing debate whether it was started in a lab, where it was accidentally released from a lab in Wuhan, China. That last night has been refuted even by American scientists. So we have gone back to the original theory. It was in a wild meat market.
But then, you know, a lot of people are disputing even the political leanings of American scientists in this particular pandemic.
And yes, I understand that there's a lot of conspiracy theories. Last night I saw a very touching interview, I have to say, with Dr. Fauci and Andrew Cuomo, who's the brother of the mayor of New York. He had COVID-19, and in fact he was getting fairly ill, and Dr. Fauci, who's a good friend, was in the midst of his busyness, was ringing him every evening, finding out how he was going. I know there are different views. I consider Dr. Fauci to be one of the experts in this field. But let's just get back to the...
Yeah, if there are any other updates that you want to share with us, because I know there's a drug situation, then there's the vaccine.
So right now there are over 109 vaccinations being trialed in trials. What I read last night, so daily I get what is called COVID-19 updates from WebMD and from the Royal College of General Practitioners in the UK. And there's an Oxford group, a group from Oxford, that has begun human trials, and they are projecting that as early as September a vaccination could be on the market. Now that is really an accelerated progress if that happens.
How long would a normal vaccine take to develop?
A few years.
Years.
A few years.
Okay. And you need to be able to observe side effects. So
first it started in animals. It's trialed in animals. That's first phase. Then there are human trials. Then they have to look at side effect profile, and then they have to look at the efficacy of the virus. So it is often a long, drawn-out process, but obviously a lot of acceleration is involved in this process. So one of the things I wanted to say as well is that the seasonal flu vaccination does not protect you against COVID-19.
No. But I have heard that if you take the seasonal flu shot, you can test positive for COVID?
I'm not aware of that. I'm not aware that the seasonal flu, in fact, I'm fairly sure that's not the case, because it's a completely different virus strain.
Does it depend on the testing kit?
No, I don't think it... Well, okay, so there are two types of testing. Basically, there's testing for the actual antigen. That's a virus, what has been done all along. And bear in mind, if you test negative today, you can contract the virus tomorrow. Yeah. So that's why they're talking about repeated testing. And this is the whole argument right now in America, and it may very well come into Trinidad. If we're going to reopen, are we going to do repeated testing of people who are going about their daily business, and then people who are coming into the country? So there's the testing for the antigen, and then there's the antibody testing, which is being made available in huge quantities, and that's testing whether you have been infected. Now, the problem is we're still, as Linda, you're right in saying, and Dr. Fauci said this last night, we know so little about this virus.
Yeah.
And there's, so one of the questions is, if you are infected, can you be reinfected?
Right. And then I know the third thing we wanted to discuss was the idea of when borders will reopen, flights will begin coming in. I had a phone call this morning from someone whose daughter is abroad and is in desperate need to come home. And I think there are over 200,000 Trinidadians living abroad who want to come in. Will they be quarantined? Will they need to be tested when they come in? Do we have enough testing kits for that kind of situation?
Well, we don't have enough testing kits at the present time in Trinidad, as far as I'm aware. Now, just to say about traveling, I read again last night that airlines like JetBlue, American Airlines, United, they're beginning to insist that people wear face masks. So can you imagine now, from the time you check in, you're going to have to, and if you don't have a face mask, they will prevent you, they'll
Provide you
with one. And you have to wear during the flight, well, checking in during the flight. Of course, if you're having a meal, they'll allow you to take off the flight. On long distance flights above maybe 5 to 10 hours, even the air stewardesses, they're being given protective gear. So now you're going to probably see air stewardesses with
looking like aliens.
Yeah, with a gong, mask, etc. So especially in transatlantic flights from here to England or to Europe.
And then I guess the spacing of passengers.
Right.
Is
So
going
they're
to be
also that's I don't know how that's going to affect the cost of flights. They're saying that they're going to fly for now at about 50% capacity.
Yeah.
But the question you're asking, Linda, about people coming when our borders, because I think the real test of this, it seems, we didn't have a chance to listen to the media briefing today, but up to yesterday, I think all the additional tests that have been done have been shown to be negative in Trinidad.
But patients 115 and 116 were, it wasn't imported, it was localized.
So, but we have not seen a lot of community, almost nil in terms of community spread.
Right.
So,
but if the last 2 patients who were tested were localized, then...
So that's where the decision on the 10th of May, the Prime Minister will have to, and his with his advisors, tell us whether they're going to have a phased reopening. I suspect we're going to have to keep wearing masks. I think my impression just driving around, because I'm still seeing patients, etc., there seems to be a little bit of a relaxation where Trinidadians are concerned. So, you know...
Yeah, it might have to do with that chart that defined us as number 1 in the world or number 2 in the world in terms of control.
Right. So that chart, can I say, is not a validated chart. Now, some of you will shout at me and say that I'm not patriotic. Can I just say, Linda, one of the things I'm concerned about is anytime someone says
or questions
a decision, you're almost being made to feel that you're unpatriotic. So I know there's a big uproar about this present Venezuelan situation. I'm not going to get political today because I have no political allegiances, although you're wearing yellow. We have no political...
Which political party is that?
How could I say? We have genuinely, we have no political allegiances, none at all. So I want to say that. But I believe in a democracy, you must be allowed to speak up and question decisions. When you start getting to a situation where people are being labeled as unpatriotic because they're questioning the Venezuelan situation with oil, or they're questioning why 35 of our citizens were left in Barbados, why people are not being allowed in, I believe you're moving to a totalitarian state. Now, I know that's being a bit excessive in my statement, but democracy...
Many people are saying that that's what the case in the United States as well, that decisions are being made almost like a totalitarian state. So it seems to be, are we equating globalization with totalitarianism, or that's another political debate. Yes. So we've looked at COVID.
One last thing, can I say that where elderly people are concerned, there's this concept that elderly people contract the virus more easily than younger people. There's a difference between saying that. That's not the case. That's a myth. Elderly people, if they contract the virus, are more at risk of complications. So they're not more at risk of contracting the virus. It's similarly people with diabetes, asthma. They're not more, although unless you have a suppressed immune system, that's you're on chemotherapy, etc. But these at-risk groups are more at risk of complications of the virus. And one last thing about COVID-19 is that there's this whole thing about about ultraviolet light being used to sterilize your hands. I saw that somewhere being talked about. There's no evidence that using ultraviolet light can sterilize your hands. The standard of care, and I think you have this here, soap and water, washing your hands.
Stay safe, everyone.
Stay right. So wear the mask. Just talking about wearing the mask, I know that wearing the mask can be very uncomfortable. In fact, I find it difficult seeing patients.
But you're breathing in carbon dioxide.
Right.
You're not getting oxygen, which
Right.
your brain needs, which your
Right.
body needs.
So there was a side, I'm on my medical reunion side. These are doctors who all graduated in 1989, including the dean of the medical school now, who are very experienced doctors. That was put on our medical site today, and it was debunked in the sense that, yes, I mean, one of the people on the site, she's a surgeon, and she's operating for 5 hours with the mask. It is uncomfortable, but the idea that if you wear it for 10 minutes, you're somehow going to do brain damage, etc., there's no scientific evidence for that. What I would say is that be sensible. If you're driving in your car, you don't have to have the mask on. But if you're coming out, I don't think it's compulsory yet, but I think if you're going into the supermarkets, if you're going out...
I think it's going to be the new normal, isn't it? Wearing the mask as uncomfortable as it is. Boosting your immune system, very important, I think.
And how do you do that?
Keeping, well, you're eating fresh fruits and vegetables. Yes. You are, natural foods that are rich in vitamin C, and we do have enough sunlight here to be able to absorb it.
So some of you may have seen that in the UK, the NHS, doctors are being advised to routinely prescribe vitamin D supplements now. Some doctors in Trinidad are doing that, but that's due to sunlight exposure or lack of sunlight exposure. And if you have a darker skin color, of course, you have more melanin, which helps with sun absorption and vitamin D levels. So we may not need to take vitamin D supplements or
in the tropics,
or even C supplements if you're eating enough fruit and vegetables. But I would say boosting your immune system, eating healthily, exercise. I just want to emphasize that. I mean, I have to say that in this
keep
lockdown,
the muscles moving.
Yes, I am finding I'm exercising a bit more. Halo, everyone can see the halo. I'm exercising because you gave me a little video, and
it's a little app that
gave
helps
me
you.
5 exercises I can do at home, and it helps you with muscle building and cardio. So you can exercise at home. You don't have to go out.
Yeah, I've just heard the catchphrase. Sitting is the new smoking. So sedentary lifestyles, yeah?
Wow.
Okay, so we're going for our first break. Thank you for joining us. We've just used this time to bring us some updates on COVID and fact versus fiction, updates on the most recent decisions with regards to drugs, vaccines, and airline travel. When we return, we will move on with our second topic, as we said, heart failure.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
Cloud 9 with your new hosts, Renata and Kimberly Singh. Weekdays at 5 p.m. on ACTN The Voice.
Welcome back to Your Health, Your Choice. We've just finished examining the recent updates where COVID is concerned, and now we're going to be delving into a different topic. It's not a contagious disease, but it is just as chronic, heart failure. So why did you choose this topic?
I think heart failure is it's quite often an underestimated medical problem. We hear about heart attacks, we hear about diabetes, we hear about hypertension. We don't hear a lot about heart failure. And the fact is, heart failure is one of the most common medical emergencies and chronic medical problems that people deal with and have to live with on a daily basis.
Okay. I guess in the midst of COVID, heart patients are one of the vulnerable groups.
Absolutely. So, yeah, it overlaps. If you have heart failure and you contract COVID-19, there's evidence that your morbidity and mortality can increase. So, that's a matter of great concern.
Okay. Yeah. So, we know it's a global burden in the midst of a pandemic as well. And just by the way, if you have any questions on this, you can WhatsApp us at 482-4269, 482-4269, and Dr. Khan will be happy to reply to you on WhatsApp.
Yeah. So there's a slide, I think it's slide 4, that I just wanted to bring up, and it shows that over 60 million patients worldwide have heart failure. Secondly, the number one reason for hospitalization in patients above 65 years old, it's due to heart failure, with 24% of patients re-hospitalized within 30 days of discharge. And I know the last one is a little bit kind of difficult to say, but approximately 50% of patients diagnosed with heart failure will die within 5 years. So we can come off that and just emphasize what we are saying here.
So in Trinidad specifically, what would you say is the rate of or the percentage then of patients with heart disease, if you're saying that 50% of them are going to die in 5 years?
So now when we say heart disease, we have to be careful. Heart failure is a form of heart disease. Now, while we have statistics for diabetes, we can say about 13 to 14% of the population are diagnosed, have diabetes. We don't have figures on that level to say what percentage of the population may have heart failure. And the problem with heart failure is it's not as easy to diagnose it, as we'll come to, as with diabetes. Diabetes is a simple blood test, but heart failure, diagnosing heart failure is a little bit more involved. So a lot of people may have early heart failure and may not know it. So yes, the statistics are startling that we're saying that over 50% of patients diagnosed with heart failure will die in 5 years' time. Now, that's startling, but it does demonstrate that maybe we are under-treating people for heart failure, and there are various reasons for that, and I'll come to that in a minute. But the fact is, it is almost as bad as some kinds of cancers. That's the point we're making, and it's also, we need to sit with our patients, and when they're diagnosed with heart failure, explain to them that they may very well have to find themselves in needing hospitalizations, because heart failure, you go into a state of exacerbation where you have symptoms, you have to be hospitalized, they deal with it, and some people may think, well, right, I'm cured.
Okay. Yeah.
But, again, the word cure, and this is where language is very important. Even when we talk about diabetes, people talk about, is there a cure for diabetes? And I say to people, well, your diabetes may go into remission, but that doesn't mean that you're cured. Similarly, with heart failure, you may go into a bit of remission, or your symptoms are under control, but it can go back into an acute state where you need to be treated again.
So that obviously means with heart failure we have a reduced quality of life.
Reduced quality of life. And so slide 5 just gives you the 6 aspects. We look at symptoms, and we'll talk about that. Physical function, so that's from the left coming across. Quality of life, what we call self-efficacy, the way you deal with everyday problems, social limitation, and symptom stability. So we can just come off that slide.
What's the last one? Symptom stability.
Symptom
Okay.
stability. So there is a so the fact is there is a reduced quality of life, and the problem is every time you have an acute event. So what can set off heart failure? I'll come to that in a minute, but it could be something like a heart attack. What is a heart attack? A heart attack is where you have clogging of the arteries leading to the heart. The blood supply to the heart muscle is cut off, and part of the muscle dies. So the heart is basically a pumping organ. So if any muscle dies, it can't work as effectively. So the heart is no longer pumping as effectively. And as a result of that, you have
Other organs that are going to be...
which we're going to come to. But so you have that initial event, you're then hospitalized, and every time you have another acute event, your cardiac function decreases with time. And although we are giving you drugs and there's a short-term improvement, there's often the declining function.
Okay. So what are the clinical implications then of...
Right. So this slide, which I believe is slide 8, shows the relationship between the heart and the kidneys. Now, I know this is a little bit of a complicated slide, but what happens is the heart, so the left side of the heart pumps blood around, and if your heart is not pumping blood out effectively, oxygenated blood, one of the things that happens is the kidneys become hypoperfused. You get the kidneys, the cells beginning to die, what is called apoptosis, right? Then you have fibrosis, and then you have on the left side of your slide, and maybe I should have showed this, but the left side, you have the renin-angiotensin-aldosterone system, the RAS system being activated, and that's what results in sodium and fluid retention, leading to overload of the heart. So you see, it's a cycle. So
The water retention is a very important part of this cycle.
Very important part of it. So we could just come off that slide, and I just want to emphasize that. So you have the heart, the left side, which is a pumping side of the heart. So you have a systolic phase and a diastolic phase of the heart. The systolic phase is the pumping phase. So if you have had the heart muscle being damaged, then the heart is not pumping, the organs are not being perfused.
What does perfused mean?
The blood is not flowing to those organs sufficiently well.
Okay.
So we're looking at the kidney in particular. So there's hypoperfusion. As a result of that, you have something called the renin-angiotensin-aldosterone system being stimulated. That's why there's a group of drugs called ACE inhibitors, like lisinoprils, the lisinopril, enalapril, Covasil, and then there's the ARBs, which act against the RAS system in heart failure. But when that system is stimulated, you have sodium and water retention. So the body then begins to be overloaded, and in the diastolic phase, which is when the heart relaxes, the heart is then being refilled and can't cope with that refilling. And then you start having a backup of fluid into the lungs, and that's where you get what we're going to come to, some of the symptoms like breathlessness, swelling of the ankles, etc.
So that illustration showed one heart and one kidney. We have two kidneys, right?
Yeah, well,
So
yes.
Are both kidneys going to be affected equally?
Absolutely, because when the blood flow comes, you have the two renal arteries, so the blood should be flowing to it's like the legs. When you have the pumping action, the blood isn't flowing to one leg first, and then the next leg you have the blood flowing equally, unless you have a blockage, peripheral vascular disease, where the blood flow is not as good as the other leg, and that's where people end up getting cramps in the calves, for example, what is called claudication pain when they're walking around. So once you have your arteries clear, blood should be flowing where you have organs on both sides. You should have equal flow of the blood to both kidneys. This is getting complicated, but the only other situation where kidneys are concerned is if you have renal artery stenosis, narrowing of the renal arteries, kidney arteries, and then you have a blockage of flow to the kidneys, which then damages the kidneys, etc.
Okay, so the statistics show that about 75% of patients with heart failure have additional contributing clinical risks.
So this is where our emphasis should be to prevent heart failure.
Yeah.
And what we call the modifiable risk factors. So, we talk on this show a lot about preventing diabetes. Well, we can prevent heart failure to a certain extent by treating these modifiable risk factors. And
what are they?
And yes, I want to spend a few minutes talking about this. So, Josh, if we can bring up slide 9. Slide 9. It's an easy to read slide. So this is, as you said, almost 75% of patients with heart failure have additional contributing clinical factors. So we start with diabetes. Diabetes is much more common in heart failure, contributes to heart failure. Hypertension, I'll explain what I mean by valve disease. Overweight and obesity. Age. Well, that's not really a modifiable risk factor, but age, as you get older.
Well, some people age better than others, so maybe genetics.
Well, genetics have, a lot to do with it. Left ventricular hypertrophy, which means enlargement of the heart, and myocardial infarction. So let's just come off that slide. There's a lot to unpack there. So we know that people...
So these are modifiable.
These are modifiable risk factors.
So that's good news.
So that's good news. So people with diabetes have a 2 to 3-fold higher risk of developing heart failure. That's why there's a new class of drugs called the SGLT2 inhibitors, things like Jardiance, Forxiga, Invokana, that have become very popular in the diabetic world, and cardiologists are using it quite a lot because there's a dual role. We are treating it, using it to treat diabetes, but we are using it to try and prevent heart failure as well. Or people with heart failure, it's very efficacious. So if someone has diabetes, and just let me come back to COVID-19. There was a webinar this morning. I was looking at part of the webinar, but there's a lot of literature coming out that people who are hospitalized with diabetes, it's crucial that their blood sugars are well controlled. Now, the problem is when people are up to this point admitted with COVID-19 and diabetes, the emphasis has been treating the respiratory condition. And can I say, this is even getting more complicated, but there's a whole amount of literature coming out on the clotting complications of COVID-19. So we are seeing young patients having strokes with COVID-19 and having heart attacks. So it seems that COVID-19 is not just affecting the lungs, but it's affecting the coagulation cascade. So it's a clotting disease as well. And this is why people who look at fake medicine a lot don't understand. Linda, I know you're smiling, but let me just say say, that's why, you really should have a proper medical training if we are going to talk about medicine. I know some of you going to resent me saying that, but I say it with confidence. If I need, in fact, I spoke to my guy who does the body job on my cars today. He's going to try and do some work on my car. Why? Because I am not a body work guy. I don't know anything about painting cars, etc. I could read about it, I could study it, but I don't have a clue how to do it, and therefore I do not comment on how to paint cars. So, ladies and gentlemen, can I just say, when you read fake medicine, make sure whether it's fake medicine or not, and make sure whether it's legitimate. Because, those of you who are saying, and then I'm not going to leave you out of this conversation, but those of you who are saying that we are overplaying COVID-19, I wish if some of you could go on the front line in ICU departments, like some of my colleagues. I get passionate about this, because you see, I talk to my colleagues in the UK who are on the front line in ICU departments, and when I hear people saying that COVID-19 is not a serious disease, it's just like influenza, you're talking nonsense. You don't know the facts. You don't know what the frontline people are dealing with. So just hold off on commenting on COVID-19, because you see, when you say that, you are then influencing others to believe COVID-19 is not a serious illness. It is it's a deadly condition that we need to take seriously, and we need to know what is legitimate medicine and what is fake medicine.
Right.
So then we're coming back to the modifiable risk factors. So we talked about diabetes.
Yes. Next.
Hypertension.
Good.
Hypertension.
You're raising mine now.
So hypertension is not fake medicine, it's real medicine. So some of you who don't think hypertension is a serious illness, hypertension is a silent disease. And even today I saw a patient who has no symptoms, but her blood pressure is slightly raised. Now, if we treat hypertension well, we can prevent heart failure. So the question would be, what is a good blood pressure? So a good blood pressure would be around 130/80. If you're younger, 120/80, for example. So diabetes and hypertension, two of the major causes.
Time for a break. Good.
Do we have to go for a break? Okay, yes.
So when we return, we'll continue with our discussions on heart failure. Your Health, Your Choice returns in a few minutes. Don't go away.
Every Sunday at 2 p.m. on ACTN The Voice, we will be taking you on a journey down memory lane with our Sunday classics. Relive the moments. Bonanza at 2 p.m. Little House on the Prairie at 3 p.m. Gilligan's Island at 4 p.m. Family Matters at 4:30 p.m. Hogan's Heroes at 5 p.m. The Jeffersons at 5:30 p.m. This is Sunday Classics on ACTN The Voice.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the Word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
Cloud 9 with your new hosts, Renata and Kimberly Singh. Weekdays at 5 p.m. on ACTN The Voice.
Welcome back to Your Health, Your Choice. We've been looking at heart failure and how it affects the quality of our lives. And we want to examine a few more signs and symptoms in the next few minutes.
So just to say that, I said about diabetes and heart failure, 30% of patients with heart failure also have diabetes. So not 30% of patients with diabetes, it's the other way around. 30% of patients with heart failure will also have diabetes, but about 2.5% higher rate of chronic heart failure in patients with diabetes. So there's a 2.5% higher prevalence of heart failure in patients with diabetes. On the modifiable risk factors, we talked about diabetes, hypertension. But overweight. And I know we don't like the word obesity, but if you're overweight, I know we're living in a time we have been seeing a lot of jokes about putting the mask over your mouth so you don't eat too much. You're at home a lot, but try and be innovative. Try not to put on weight, but weight is often genetic as well. So some family lines find it more difficult, and that has to do with metabolic rate. Some people's metabolic rate is slower. We have no blood test to prove that, but it is slower. Looking at, I think you were asking about symptoms.
Yeah, signs and symptoms, yes.
Okay. So
we usually look at a definition and then we talk about signs and symptoms.
So this is a very important slide, 13. As we go to that, I just wanted to say, what do we mean by symptoms and what do we mean by signs? So symptoms is what the patient complains about. Signs is what the doctor detects when he examines the patient. That's why, and I'll come back to this, the way we make a diagnosis is based on a history, examining the patient, and then doing the appropriate investigations. So some of the most common symptoms of heart failure is breathlessness, and I want to emphasize what I mean by breathlessness in a minute. Something called paroxysmal nocturnal dyspnea. That is where you get up in the middle of the night short of breath. So you're sleeping at night, you get up and you're very short of breath, you have to open the window,
it's like oxygen deprivation.
Oxygen deprivation. Now this is not obstructive sleep apnea, but this is a different condition. Orthopnea talks about having to sleep on 3 or 4 pillows propped up, and I remember my mother used to have to do that. Reduce exercise tolerance, fatigue, tiredness, increased time to recover after exercise. Now ankle swelling, and I need to explain that. As opposed to that, we have the signs, which I don't want to go too much into because this is more medically, but when we examine patients, we look for something called elevated venous pressure, hepatojugular reflux, third heart song, a gallop rhythm, pulmonary rales or sound of crepitations on the lungs, displaced heartbeat, and a cardiac murmur. So we could just come off that slide.
And if you have any questions about any of that, remember you can WhatsApp Dr. Khan on 482-4269 and he will reply to your questions, because that was a lot of information.
Yes. So can I just say, when we talk about breathlessness, I mean, if you're unfit, you'll be breathless walking up a hill. So I'm talking about really after just walking a few meters, you become short of breath. Well, we talked about what we mean by paroxysmal nocturnal dyspnea. Reduce exercise tolerance. Again, if you're not exercising, I mean, I now find that the first few days I was exercising, I could only run once or twice where I was running. Now I can do 5, 6, 7. I was doing some sit-ups. I could only do about 10 or 15. I can do about 40 now. Halo, right? The push-ups. So exercise tolerance. The one I want to, fatigue and tiredness. Please. A lot of people complain about being tired all the time. It's not necessarily heart failure. Tiredness could be due to a low blood count, could be due to poor physical conditioning, could be due to diabetes, could just be due to stress. tiredness, and ankle swelling. Now, this
Is it connected with the sodium and
right,
the
fluid
water retention? Yeah.
But a lot of people have ankle swelling because of venous insufficiency. The veins are not draining the blood from the ankle, and you get swelling around the ankle. That's the most common cause I see for ankle swelling. The kind of swelling we're talking about is really, that's just around the ankle. It's coming up the leg. It's pitting edema. By that I mean you press it, and there's depression as you press. So we need to be careful when we tell patients about this, what we're talking about.
Okay. I see you're pulling up another slide.
Well, I'm not going to show the slide.
What it's about.
Right. Okay. So the key to this whole thing about heart failure is what we call ejection fraction. So ejection fraction is the amount of blood that is pumped out of the left side of the heart as compared to what's coming in. So it's the fraction of the blood that comes in to the heart that is then pumped out as oxygenated blood. So an ejection fraction of 50% and above is considered fairly acceptable. Really, maybe at a young age you'd have an ejection fraction of 80 to 90%.
So this is a test that we need to do.
Right. So the art of doing medicine is taking a good history, so listening to your patient carefully, taking a proper history, doing a physical examination, not just taking a drop of blood and putting it under a microscope and coming up with a diagnosis, but doing a physical examination, which means being trained how to use a stethoscope, being trained how to listen to the lungs and to the heart, listening for what we call a gallop rhythm, examining the abdomen, feeling over the liver, because what is called the hepatojugular reflex is when you press on the liver, you see the veins in the neck being distended, and then examining looking for ascites, which is fluid accumulation, which you can get with heart failure and also kidney failure, and then doing the investigations. So the two key investigations, well, three really. You can do a chest X-ray, but a chest X-ray is very rough way. It's just giving you the initial, if there's a lot of what we call pulmonary edema.
You'll have an enlarged portion of the heart.
Absolutely. Then you'd have made a good doctor.
I went to my grandmother's, but to the heart specialist a lot.
Right, okay. so yes, you'd see an enlarged heart,
Yeah.
but unfortunately, by the time you pick up an enlarged heart on a chest X-ray, it's sometimes very advanced, and also chest X-rays are markedly inaccurate because according to the size of the chest you can get different features. So you do an ECG,
Right.
electrocardiogram, and you may see some signs on the electrocardiogram, but then the key definitive test is the echocardiogram. That's like an ultrasound of the heart. So it's not a angiogram, it's an echocardiogram. It's a little probe passed over the heart. It's done by either technician and then interpreted by a cardiologist. And you can look at the chambers of the heart, you look at the valves, and then you look at what is the ejection fraction.
So I guess the bottom line is that the quality of our lives is definitely going to be affected, and because of the functions of the
Yes.
heart not working as they would. What about these classification methods?
How much time we have again?
We have about 9 minutes.
9 minutes. So Josh, if you could bring up 21, slide 21. These are two classifications that are often talked about by medical doctors. One is called, the one on the right is the one I would kind of emphasize, because that's the one that's more often used. It's a New York Heart Association, NYHA, New York Heart Association. So stage 1, which is almost normal, no limitation of physical activity. Ordinary physical activity does not cause symptoms. 2, slight limitation of physical activity, comfortable at rest, but ordinary physical activity results in some shortness of breath, etc. 3, marked limitation of physical activity, comfortable at rest, but less than ordinary activity causes symptoms. And then stage 4 is fairly severe. It's where you are unable to carry out any physical activity without symptoms, even getting out of a chair, walking, you have symptoms of heart failure.
Right. Any good news?
Well, the good news is that we can treat heart failure. So we can just bring up slide 25. Slide 25 talks about, this is the European Society for Cardiology guidelines, outline the main treatment goals. So we want to improve the clinical signs and symptoms. We want to improve functional capacity. We want to improve quality of life. We want to prevent hospitalization, and we want to reduce mortality.
Okay.
We can come off that slide. I know we don't have much time left, but I just wanted to talk about the drugs. So, you know, the problem with treating diabetes, heart failure, coronary
non-contagious diseases.
It's communicable disease, non-communicable diseases.
Yeah.
And patients have a big drug burden, number of pills. That's why we are moving more to combination therapy, because, you know, when patients have 10, 11, 12 pills to take, very often they pick and choose. And you ask patients, you know, every time, you know, about their drug regime, and they will tell you, oh, well, doc, I take my aspirin once every 2 days. I take my statin. And of course, bear with me, Linda, I know you don't like me talking about fake medicine, but we have all the anti-big pharma conspiracy theories that Big Pharma has us as doctors in their back pockets. I want to tell you that is a lie. It is not true. Yes, we do meet with pharmaceutical reps, but we do our own research. So the science behind the use of drugs, so beta blockers, things like Coreg, Bisprolol, and there's some newer beta blockers. We used to think that beta blockers were not helpful in heart failure. Now we know that beta blockers are. What we call ACE inhibitors, or ARBs. ACE inhibitors, so that's like the prils, enalapril, lisinopril, etc., ARBs. We have a new drug, Vimeda, which the cardiologists are using quite a bit. We have aldosterone, we have hydralazine, so I know people don't like when we talk too much about drugs, but...
Well, if I could just interject here and make a plug for people who have been reading up on the history of Big Pharma. There is no doubt that they have made millions and millions, and the FDA did have to cut down on what they were, the amount of drugs that they were putting out there. And now the emphasis is on vaccines, which they say is the new money spinner. Now, I'm not saying that, I mean, we know that the quality of our lives is going to be affected by heart failure, and we do need to take medication in order to become more, to improve the quality of our lives if we are susceptible to that kind of disease. But at the same time, you know, how much of this medication are we taking? And if you're taking 12 different kinds of medications for one particular area of weakness in your body, then there are lots of other side effects that we need to take into consideration as well.
What we need to take into consideration is the side effect of dying from heart failure, as opposed to the side effect of that we as doctors are trained to monitor our patients. So, you know, I always say to patients when they come to me for their diabetes, when was your last lab test? Not a finger prick looking under the microscope. I'm talking about a proper lab test where you go and you get your kidney. So if I have someone on metformin and someone on Jardiance or Diamicron, every 6 months or sometimes every 3 months, I'm doing their kidney function, I'm doing their HbA1c, I am monitoring. So the art of doing medicine is not just history taking, physical examination, doing the investigations, but when you come to a diagnosis, is coming to a treatment plan. Now, I have to say to you, Linda, I totally agree that maybe in Trinidad, we don't always have the resources for the team approach. The team approach. So people with heart failure should not just be placed on drugs. They need physiotherapy. They need occupational therapy. They need guidance on exercise. That's where we fall down. So I agree that, yes, sometimes we are pumping people with all these drugs and we are not having the holistic approach.
Yeah.
And I think we do need to have a more team approach to heart failure, where we have the drug therapy, but then we have all the ancillary stuff that can help these patients improve their quality of life. And of course, at the end of the day, quality of life is very important.
But quality of life also hinges on whether you can afford the medication or not.
And the sad fact, absolutely, Linda, the sad reality is that on the government service right now, we are very limited in terms of treating diabetes. Very limited in treating heart failure. Most of these newer drugs are not available. I am not laying blame at the feet of anyone, but one of my challenges right now, I'm no longer working for the government services, but when I hear patients, I think there was some time ago when I was working in one of the health authorities, I could prescribe medications to patients, and if we didn't have it, ask them to buy it privately. I understand now in some of the health authorities, doctors are being told they can't do that because legally. So I have a big issue with that. I know time is almost gone.
Yeah, we have 1.5 minutes left, and I know you need to put your pastor's cap on and maybe just compensate for some of the negativity that we saw before.
So as I put my pastoral hat on, I am confident in what I've said today, but seriously, I know Linda and I have, that's why, husband and wives, so you all enjoy our banter. Can I just say, last Sunday in our online service, and by the way, you can join us on our Facebook site, the Trinidad and Tobago Anaposis Center, 9:30 on Sunday mornings, live on Facebook. I taught on being confident in God. Not self-confidence, but God confidence. 3 things I want to leave you with. You can be confident in God because God is always for you. You do not work for God's favor, but you work from the favor of God. 2, God can always be there to help you. And 3, very reassuring, with only 30 seconds left, God is not finished with you yet. God bless you. Linda, over to you.
Okay, well, thank you for joining us again on another edition of Your Health, Your Choice. And Dr. Khan, and with all of his information and very informative, very educational information on not just heart failure, but the updates on COVID. We'll see you again in a fortnight's time.
Mother's Day.
And happy Mother's Day.